Welcome back for the first Cardiology Countdown of 2013. We'll have studies with different diabetic strategies, also use of anticoagulants and antiplatelet therapy, and an interesting new look at an approach to heart failure. So beginning at the number 3 spot, we have a study on the relative effects of metformin as compared with the sulfonylurea glipizide. This was a small study, but one with long-term follow-up done in China, where they randomized 300 patients to metformin 1.5 grams a day or glipizide 30 milligrams a day. And they found similar improvements in glycosylated hemoglobin and all the other parameters, but the rate of cardiovascular events, cardiovascular death, MI, stroke, or need for revascularization was about half in the patients treated with metformin. This has been listed as the frontline therapy in most guidelines, but this is a nice direct comparison to another contemporary, although older therapy, and I think reaffirms the place of metformin as the first-line anti-diabetic agent. Next up, we have a study that's a sub-study from the RELY trial that looked at the new oral anticoagulant dabigatran as compared with warfarin in patients with atrial fibrillation. And this analysis looked at 38% of the group that had concomitant antiplatelet therapy, either aspirin or clopidogrel. For a brief period of time, some patients even got dual antiplatelet therapy. Now, they found that comparing the two different groups of patients, those who had antiplatelet therapy versus not had a higher risk of bleeding, not surprisingly. But comparing the different anticoagulant strategies, the effects were very similar with or without antiplatelet therapy. And so overall, and what was seen in the subgroup on antiplatelet therapy, the patients with the 150 milligram dose, the FDA-approved dose, had a greater reduction in stroke or systemic embolism and about equal rates of bleeding as compared with warfarin, in that case both with antiplatelet therapy. But then the 110 milligram dose, which is available worldwide, everywhere except the United States, was seen to have a lower risk of bleeding and equal efficacy to warfarin. Now, this is not with dual antiplatelet therapy, but really single antiplatelet therapy, but does raise the notion that in those patients that have a higher risk of bleeding due to concomitant therapies, use of dabigatran 110 milligrams might be a way to reduce the risk of bleeding. Again, not currently available, but maybe coming soon at the FDA. And the top pick this week is an interesting review and opinion piece about how to manage heart failure. As we know, admissions for heart failure is the biggest increasing reason for cardiac admission in the United States, and will only get worse as the population ages. And so a group of cardiologists put together a review on the concept of using the emergency department observation unit as a way to triage and manage for a briefer period of time patients who present with acute heart failure. They note that this would obviously involve triage with the highest risk patients with worse heart failure getting hospital admission, but they indeed propose a randomized trial to compare inpatient versus observation unit management. Much of the management would be similar, including laboratory evaluation, diuresis and vasodilation therapy, but also then education on trying to prevent rehospitalization. So a terrific piece in JACC that I encourage all of you to take a look at. So for this year's first Cardiology Countdown, I'm Chris Cannon.